What an incredible honor this is, an honor of a lifetime. Thank you so much, Banshi and Sanjay and the entire RSSDI organizing team for giving me this absolutely great honor. And my life is not as dramatic as my sister Neeta's. So I cannot give you those, I didn't fall into any kind of a ditch and nobody rescued me. But I have to tell you, this has been an amazing, wonderful, great honor and great career. And over the next 30 minutes, I want to talk to you about women and diabetes. And I'm just so thrilled that the majority of the room are men, because I really need you brothers to stand with us to take this concept forward. Thank you so much. So talk about some myths and misconceptions. A few words were said about Professor M.M.S. Ahuja. I didn't have the good fortune of being trained by him, but the year before he died, in 1997, I was in Lucknow for the Endocrine Society of India meeting, and I happened to sit in the bus next to him. I have to tell you, it was a spiritual journey. The whole time I felt like I was sitting next to the god of endocrinology, and he spoke Tamil, and he from Madras Medical College, which I knew only on that day. But what an incredible honor just to have that journey with him, and I feel that he blessed me on that day. So so especially I'm honored to be giving this oration in his name, because in the endocrine community, he's not just considered a visionary, he's the true father of endocrinology for us in India. So such a great honor. So go back about 4 years, because until that point, till 2017 World Diabetes Day, every time any of us spoke on women and diabetes, it was just another, a novel kind of a topic, or even something like a feminist kind of an approach. But in 2017, the theme for World Diabetes Day, by the way, which is tomorrow, World Diabetes Day, was women and diabetes. So this was the editorial that was written in the Lancet. On November 14th this year, which is 2017, the focus of World Diabetes Day is women and diabetes, our right to a healthy future. So here I want to also thank Banshi and Sanjay and the organizing committee for including 2 women in the 4 orations. So that kind of 50% representation is a must. And I urge all scientific programs and committees and grant-making organizations and funders and everyone should have that 50% must be given to women. So I really thank you for doing that. Thank you so much. So the editor said, with ever-increasing evidence that diabetes adversely affects women more than men, this timely theme and help to boost awareness of the need for specific approaches to prevention, treatment, and education for girls and women with diabetes worldwide. So that was 4 years ago. And fast forward, the pandemic happened. So in this slide, you can see what is the wider impact of, and I'm grateful that Dr. Jha spoke about COVID-19, because while more men were affected by COVID-19, and more men died because of COVID-19, women were affected in so many different ways. So you can see here, non-communicable diseases are going to be the pandemic behind the pandemic. More women, and I'll show you, the reproductive services, maternal and child health services, all have gone into a deprioritization phase. And so this is going to have far-reaching impact, and COVID-19 has pushed 47 million more women and girls into extreme poverty by 2021. And again, to reiterate what Professor Jha said, that the poor are getting affected by diabetes in our country, and more people are going to be in poverty. So the theme for tomorrow's World Diabetes Day, again, a brilliant, apt concept, access to diabetes care, if not now, when? So thanks IDF for doing this, because I really think that in 2017 and 2019 and 2021, whoever is deciding these themes has done a marvelous job. And I want to thank also Professor Sadikot, because in 2017, he was instrumental in I think, pushing that women and diabetes concept. So as far as myths and misconceptions and reality, which is going to be the essence of my talk, there are a few things I really want to dispel, which is all diabetes is the same, all women are the same, all treatments work the same way, or even diabetes is more prevalent among men. And I'll show you some data why that itself is a myth and misconception. So all I want to say is fasten your seatbelt, because you're going to see some stuff that is very, very surprising. So look at these numbers. First of all, in the world population, there are 65 million more men than women. There are only 18 million more men having more diabetes. But look at the next year. In 2030, it's dwindling down to the difference as 14 million. By 2045, that is dwindling down to 11 million, which means this gap is getting closer and closer and closer. So that is one important thing. Even if there is a difference, the gap is getting closer, and that is something to keep in mind. Then moving on to the next one, we did a big study called as the in-depth study in the 6 districts of Tamil Nadu, and we found in every district there were more women with diabetes, in every district. And I can explain some of the reasons why. And this is a study done by Dr. Nandita Arun and Dr. A. Ramchandran's group, a brilliant study that they've done. And it shows, and if you look here in the women, whether it is the city or the town, only in the village the rise was little. But if you can see in the city and the town, between 2006 and 2016, the rise has been much more in women compared to men. So this is very important to look at. Now, this is a very, very telling thing. This is the lifetime risk of developing diabetes in urban metropolitan India. And if you see here, you take a 20-year-old man has a 55% chance of developing diabetes. A 20-year-old woman has a 64% chance of developing diabetes. So the lifetime risk is more. So if you add all this together, and I'll show you later about something about pre-diabetes, I really think we should be looking at the women, not let them out of our sight for more reasons, more than one, because diabetes is going to be the biggest problem. Now, this one, and I have circled IFG and in men and 2-hour post-OGTT in women. So the predominant metabolic traits. So if a large public health survey is using fasting sugar or a random sugar, they're going to pick up more men. Unless we do a 2-hour GTT or a A1C, or things like that, we are going to miss the women. So this may be another reason that is contributing to why they have picked up more men. So this is very important. Now coming to drivers of diabetes. The drivers of diabetes in men and women are so different. And here again, I want to say something I say in all the meetings. Men and women are equal, but not the same. So because of that, we have a unique life cycle, a precious, special life cycle, but a life cycle that's not friendly to diabetes. So I just want to show here, you look at the drivers of diabetes in women, the same urbanization, globalization, obesity, sedentary lifestyle, everything that applies to men applies to women also. But on top of that, add pregnancy, add GDM, add PCOS, add menopause, and add low birth weight, which applies to men and women, but I'll tell you what it does when it happens to women. Low birth weight. And when a mother has diabetes, her daughter has an increased risk of gestational diabetes and diabetes. And then stress and caregiving. Caregiving is a unique responsibility of women, whether it is children, adolescents, married women, later in life, their spouses. Women are throughout their life caregivers, and caregiving comes with, caregiving fatigue, inability to care for themselves, financial difficulties, so many things. Caregiving increases the risk of diabetes. The last one is about financial dependence and actually healthcare disparities. More women in the world are poor. If you take all the poor in the world, more of them are women. So that again contributes to diabetes in a big way. So the question comes, you look at all these drivers, is it biology? Is it life cycle? Are these social determinants of health? Or is it behavior? It's easy to blame behavior. So it is biology, because you can see here both physiologic and pathologic differences exist between men and women at so many levels when it comes to insulin resistance or body fat or how they metabolize lipids. In so many ways, there are sex differences. Sex is biology, then gender is different. So then comes also when women go through pregnancies, they have this gestational weight gain, which doesn't melt off and disappear like what happened to Neeta. And so it doesn't disappear. Some of us keep it back. So in the post-gestational age, in the phase, many women have gestational weight gain, and this again contributes to future risk of diabetes and cardiovascular disease. Then comes social determinants of health. It is these social determinants of health that make a lady, a woman who is born a woman by birth, turns into a woman in her life through these social determinants of health, whether it's childhood experience or lived, the built environment or housing, education, social support, family income, employment, communities, access to health services. Then comes things like air pollution, which is a driver of diabetes, and it's a gender issue. Now, this you can blame on their behavior. People sitting down, sedentary lifestyle, watching television, or using their mobile phone and things like that. That is behavior as well. Now, so why should we really talk about women and diabetes? Is because of this one very important thing, which is you take all the continents in the world except North America, more women die of diabetes than men. The mortality is much higher in women than men. And you also see what they are predicting, what the IDF is predicting, or what has happened between 1995 and 2015. In over these 2 decades, mortality has gone up so significantly in women. So why is this happening, this higher mortality? And that's what we should discuss now. You can see there vascular disease. And again, I thank Neeta for setting that context of vascular and pre-diabetes. So sex differences in the risk of vascular disease associated with diabetes, whether it's coronary artery disease or stroke or vascular dementia or end-stage renal disease. And now there's 26% more cancer in women with diabetes compared to women without diabetes. In men, it is something like, I think, 19%. So women have more cancer also when it comes to diabetes. Now, when it comes to heart disease, this very interesting slide, whether it's age-adjusted or multiple-adjusted, women have a higher risk ratio for heart disease. And you also can see, compared to women without diabetes, the gap is so much wider compared to men with and without diabetes. The symptoms are different in women, so this is important to recognize. There are gender differences and even in the way that physicians take care of them. Less angiography is done in women compared to men. Less exercise ECGs are done in women compared to men. And this is a very important thing. These risk factors for cardiovascular disease in women that are under-recognized risk factors. We know about sex-specific risk factors, and now you see how different men and women are, whether it's premature menopause, GDM, or hypertensive disorders of pregnancy, preterm delivery, low birth weight baby, PCOS. So now pregnancy should be considered as a window to future chronic disease. If a woman has a healthy pregnancy, she has less chronic disease in the future. If she has any of these complications, she's a marked person and has much higher risk for future chronic disease. But there are also some under-recognized risk factors like psychosocial, depression, abuse and intimate partner violence, socioeconomic deprivation, and what I mentioned, the social determinants of health, in addition to diabetes and other established risk factors. There are key differences in heart failure and in diabetes. Women are more likely to have preserved ejection fraction heart failure compared to men who may have a reduced ejection fraction. But this is something that is important. What about clinical trials and studies? Women, cardiovascular disease in women is understudied, under-recognized, underdiagnosed, undertreated, and women are underrepresented in clinical trials, and this is something that we can change. Stroke is also much higher in women compared to men, and this has been proved in multiple meta-analyses and in smaller studies. Now, so what is this? Why is this happening? And what is the missing piece of the puzzle? And I really want to stress home only one point in this oration, that pre-diabetes is the missing piece. So we are actually missing the boat and dropping the ball if we miss pre-diabetes. So I'll tell you why that is happening. Look at this CARS data from Dr. Mohan's and Dr. Nikhil Tandon's group, the CARS data, which shows that in Chennai and Delhi, there's something like 30 to 40% of the blue dotted lines are women, and you can see how much pre-diabetes they are having. 30 to 40% more pre-diabetes in Chennai and Delhi. And this is a very important slide. Sex differences in visceral and subcutaneous fat and association with time of diagnosis. So women have to get more subcutaneous fat before they get a critical amount of visceral fat for them to develop diabetes. So there is a lag period of about 2 to 3 years that they get diagnosed later, which also means that they spend a long time in the pre-diabetes phase. And what's happening when they are spending it in the pre-diabetes phase? Things like generalized obesity and visceral adiposity, all that is accumulating. They might develop the metabolic syndrome. So this is a beautiful slide if you can see there. Women have a longer duration of development of type 2 diabetes than men, which also in other words means they're spending a long time in pre-diabetes, by which time all these other CV risk factors are accumulating, which is why they probably are having a higher risk of heart disease later on with diabetes. All pre-diabetes studies have shown that whether it is lifestyle or with medications, you can reduce microvascular and macrovascular complications. And possibly we have to push this concept that the clock is starting to tick earlier among women. This is the important thing to keep in mind. Again, Dr. Nandita Arun and Ramchandran's group have shown the amount of pre-diabetes in our women is also escalating enormously compared to the men. This is very, very important slide to look at. And also the cardiovascular risk factors like dyslipidemia, waist circumference going up, generalized obesity, and hypertension increasing in women in these 10 years. Now there is another really important thing in women, the pregnancy aspect, which is increasing their risk for future type 2 diabetes and other complications. And look at the top panel of the slide. The pre-pregnancy risk factors are things like obesity, family history, and advancing age, and all of them. So that is really all of those things. Some of them are modifiable and some are not. All of these can be addressed in the preconception phase, and otherwise we are not going to be able to bring down the risk of GDM. Gestational diabetes increases the risk of type 2 diabetes, not just in the mother, in the offspring. There's recurrent GDM, and also in the offspring, visceral adiposity and adiposity. The one that I have circled in dark lines is really the most important thing, which is cardiovascular risk goes up in women who have had GDM, in addition to the risk of what they might get if they have type 2 diabetes. Just on the basis of GDM, they have an increased risk of cardiovascular. And babies who are born small, they are big metabolic and endocrine problems later in life, because these babies are also at risk for future type 2 diabetes and cardiovascular So here, we always talked about the Barker hypothesis. Today, I want to introduce a concept, the reverse Barker hypothesis. Reverse Barker hypothesis is when a baby is born small, it actually shows you the mother and even the grandparents who might be at risk for non-communicable diseases in the future. So keep that in your mind, reverse Barker hypothesis. So the developmental origins of disease, we know from what is happening to the mother and the baby during pregnancy, has far-reaching long-term complications, including osteoporosis in later life. Now, mother's birth weight, we always thought is something that is going to increase her risk for diabetes and cardiovascular disease. Also want to show you her risk for gestational diabetes is higher based upon her own birth weight. So one of the important things that we want to keep in mind is how to optimize the birth weight, because as you can see, gestational diabetes is not just a driver of diabetes in one generation, in the next generation and the next generation. So it has both a transgenerational impact and a multi-generational impact. We always thought of gestational diabetes as only causing these problems. Now there is emerging data to say that it is also increasing the risk of respiratory problems in the offspring, leading to chronic obstructive lung disease and lung problems in the offspring. So it's a complete menu of non-communicable diseases that can happen. That's why I have put a baby inside the baby, that this is as transgenerational impact and not just, multi-generational impact, not just a transgenerational. In addition to this, I mentioned right at the beginning, and the drivers of diabetes, that women have a lot of stress and caregiving. As such, women have more depression, twice as common. But when you take diabetes, it's again 2 times more common than the men who have diabetes. So depression is a very big problem in women, and depression has bidirectional relationship with diabetes. More depressed, poor diabetes control. Poor diabetes control, more depression. So we need to work on both of them. But in addition, I just want to show, when a mom is depressed, see what is happening to her newborn and her child, having long-term neurodevelopmental issues, and this again is something we have to pay serious attention to stress during pregnancy. What happens as a woman grows older and has menopause? And I have time just to talk about one thing, that diabetes is one of the complications of diabetes is osteoporosis, low bone mass, and increased risk of fractures. If we don't pay attention to that, you will have very good A1C, but she'll die of a hip fracture. So we have a moral responsibility not to have this narrow lens of looking at women as just as reproductive health, and to actually have the gender lens should be applied through the entire whole woman, and therefore we need to take care of bone health and heart health and mental health and all aspects of the entire woman. Now the pillars of diabetes management remain the same for men and women: nutrition, physical activity, and self-monitoring, and stress reduction, surveillance for complications, medications, motivations. But how we do that is really important, and nowhere in any of the professional societies' guidelines is anything mentioned about women. Completely, they've been tone deaf for a long time, though we have repeatedly talked about it. They have not included that. And only thing that we are suggesting is not to be very myopic and look at it just from an A1C perspective, but to actually look at our women in their reproductive years. I'm going to give you a number. There are over 300 million women in India alone, who are in reproductive years. India alone. 40% of all women who have diabetes are in their reproductive years. So we first have to know, are they in their reproductive years? Are they planning a pregnancy? Are they sexually active but don't want to have a baby? Are they done with their family? How long will it take to ask these questions and tailor our treatment according to that? Or if they are postmenopausal, are they at risk for osteoporosis? Are they at risk for CV risk? Do they have some other issues, stroke, dementia? So unless we have a guideline and these filters in place, it's going to help us practitioners in a big way. And I'm hoping all this noise that we are making will, make the the powers to be change the guidelines. I also want to say that not all medication work the same in men and women. And just to show you, if you look at the lines for SUs and if you look at the lines for, TZDs or DPP4s, there's a big difference between men and women. So SGLT2 works better. And you also look there, non-adherence and non-adherence related to side effects for financial reasons. All of these things are bigger problems in women, and this is something that physicians have to take note of. So this was published in the Economic Times, where they said that while women knew that they had to have regular checkups and all those things to prevent, to control diabetes, but only 50% of them had themselves examined for diabetes. In our own study, we found only 12% of women had diagnosed their diabetes by preemptive health checkups. The others went in when they had symptoms, or they went for something else and were found to have diabetes. Only 12% were diagnosed by preemptive health checkups. So the perspective of a woman, the experience of a woman having diabetes is very different. What she's worried about is very different from what men worry about. So we need to address that. And in a big study, and I want to show you, published in the Indian Journal of Public Health by Neetu Suresh, very good study which showed failure to provide, our part, healthcare providers, failure to provide adequate health information and unsupportive nature of health professionals were the largest number of studies in this big meta-analysis. So I think now we know how much we need to tell our patients and empower them with knowledge. They are disempowered. So this is a slide that summarizes everything I've been saying so far. So there are men and women who have normal glucose tolerance. They get exposed to risk factors. They get diagnosed. Women may have a longer diagnostic delay than men. They get diagnosed with type 2 diabetes. Women may have more inadequate risk factor screening than men. They undergo, let's say, annual screening for vascular complications. Then they may or may not have vascular complications. And then higher relative risk for women even there. They may get started for primary prevention, not get started for primary prevention. So women may be more likely to not receive adequate interventions than men, and more likely to also be not adherent to treatment for financial reasons, other logistic reasons. They may have other barriers. So very quickly in the last 2 minutes, what are the solutions? I think we've been trying to fit a round peg into a square, meaning what works for the goose doesn't work for the gander, or what's good for the goose is not good for the gander. We really need to rearrange our thought process. Let's start listening to the women, and also stop admiring pathology and start treating it. We have admired pathology enough, I think. And this I borrowed from my dear friend from Australia. So, is that thing for me to stop? So it's a complicate, that was a loud message. So stop admiring pathology and start treating it. So you can see during the plasticity phase, if we actually put in preventive measures and start treating, we actually can prevent long-term complications. And realize that women, we really need to listen to them. They are experts in their own body. So when they tell us something, it's really important to pay attention to that. And one of the biggest success stories in the world has been the Go Red for Women campaign, the American Heart Association's campaign. And I think we really need something like that for diabetes in our country and globally. And what we are doing is, and I thank Neeta and Shalini and Archana and all my buddies who are here, who have done an amazing job of joining hands, and we are working on promoting awareness and working on preconception care. And we have just launched a project called Didi, and which is Diva's Integrated Diabetes Initiative. So Didis are on their way. There are also our male colleagues who are part of that. I thank everyone for that, and thank you RSSDI for this incredible honor, and honor of a lifetime. I'll cherish this forever. Thank you.